Okay. Good morning, Dr. Fabian Bitan. Am I saying that correctly?
Perfectly.
Okay, good. Well, welcome here. It's Saturday morning, 9 o'clock your time, 10 o'clock my time, here with the ADR Support and Education Group. And I want to thank you very much for coming on board with us to do this. It's been quite difficult to get some U.S. surgeons, and I'm glad after talking with you that you are our first one, because I think you're going to highly impress the group with all your information that we talked about. So I'm just going to go through that questionnaire just a little bit and maybe highlight some things. Cervical ADR surgeries, you've done about 400?
Approximately 400. And mostly exclusively in the US. When I was in Europe initially, I've done only lumbar discs. So I started cervical here when the FDA approved the first one.
And that's, I kind of start a little bit into the questionnaire. Let's start a little bit about your training and why you got into the field you are, why you've kind of been more of on the forefront of ADR or TDR surgery. We kind of use those words synonymously, and hopefully you're not confused. But just tell me about your progress through medical school and what you've seen, what you don't. The great thing is you trained in France, which I tell everybody, to my opinion, I think it's probably one of the best programs in the world as far as spine surgery is concerned. And a little bit of history about me. Some people don't know this. I started out as a spine rep about 15 years ago with Metacrea. And I worked with Metacrea years ago in the scoliosis, using their PASS LP. I'm not sure if you're familiar with that, and sold some of their things. But Metacrea is a big French company. And, they were kind of running the show over there into our office in New Jersey. And I had a big territory here in the South as well. And that's what kind of got me into all this and in the degenerative therapies and, all the different directions. But I also saw a lot of problems like you have. And we're obviously trying to, make those problems less. But that's what I said. So give me just a little bit of your background and why the directions you have, and we'll go from there.
All right. I was born in Paris, kind of a long time ago. And I went to medical school in Paris. And I went into spine surgery because initially I was interested in microsurgery, hand surgery. And then I switched, I had an experience with a spine case, and I found that it was a good combination of orthopedic surgery and nerve surgery. So I got interested into spine, and I finally made the decision to go into spine. And I don't regret it, I love it. And as far as the artificial disc, it's, it's sometimes a question of being at the right place at the right time. When I did my residency, I was lucky to be trained by a surgeon who at that time was really at the forefront of artificial disc. He was a pioneer. And some people were looking at him laughing a little bit. What is he doing? His name is Thierry David. And I was his resident, and I scrubbed with him, and I did several cases with him. I was very young. I was at the beginning of my residency. And little did I know that this will orient my career in the long run. And I've done many in private practice. I did that in France. That was a Charité disc at that time. And then I had I was lucky enough to meet with the lady who invented the Charité. She's a German surgeon, and we did cases together. And all of a sudden, I become more and more involved. And the second event that happened is when I came to this country, it just happened that the FDA decided to be interested in artificial disc. And here I am again at the right place at the right time. I was the only surgeon at that time in the United States who had any experience with artificial disc. And so the company who was studying this disc, I think the name was Link, contacted me and asked me if I wanted to be one of the principal investigators of this FDA trial. And here I am running this New York investigation. And since that day, basically, it's been my trademark, basically. And I've done, I wouldn't say more than anybody. I don't know how many, how the people have done, but cervical and lumbar I've probably done 1,000 of a disc. I went from one to the other, of course, limited by the restriction of the FDA. And I don't operate in Europe anymore. And so that's how I got involved with all this.
You know, it's fantastic because we hardly speak with folks like you here in the United States that really have that background and that, you know, that value of it all. Let's go through cervical first and then lumbar. What disc have you used, and then what is the disc you're finally using, and why? And same thing with lumbar.
I was trained with a Charité disc, of course, and as I said earlier, I ran the New York site for the FDA trial. I've been teaching the Charité disc at that time when, after approval, there was a massive training program in Cincinnati, and I was flying, I think, every 10 days for 4 days, teaching probably thousands of surgeons in a huge lab over there. And I enjoyed it. That was fun, and that was interesting. And there was a group of orthopedic surgeon and neurosurgeon. It was probably 50-50. And that's the only disc I used for a long time, probably 350 cases. And then the ProDisc was approved, and I was interested in it. Honestly, I became very good at putting the Charité disc, but and I had good placements almost all the time. However, I realized it was a very difficult disc to place properly. It was very hard. And I remember I made the day I did my first ProDisc, I made this joke to the rep, and I said, you know what? My first ProDisc is easier to insert than my 350th Charité. So yeah, that was the big relief. And nothing against the Charité. I mean, that's what started the whole thing, but the ProDisc was a big progress of that. And so I used it, and of course, I've been limited by the FDA restriction in terms of the new disc that they can use in Europe. And so far, I'm using mostly the ProDisc. I tried the Medtronic metal on metal. I liked it. However, I forgot the name of it, but it was very bulky with the big screws. And also I have a couple of patients who was complaining about they was hearing the metal on metal movement, and it was unpleasant. And so I decided it was probably not a good idea. And more recently, the M6 cervical has been approved very recently. And I've been contacted by the company, and I'm going to training actually in a few weeks to California, and my center might be the first center in New York to use the M6.
Who's doing the training in California? Is it Landman?
I'm sorry?
Who's doing the training in California, Dr. Landman?
I think so. And so they have two sites for training. There's one over there and one in Dallas. And then so they chose to fly me to California, which is a nicer place to go anyway. and we're gonna have an intense 2 days training on cadavers, and I'm very excited about it. I don't know if I like it or not, but there's been so much talking about this compared to the ball and socket that I'm very excited to see what it is and how it works. I think some have been implanted already somewhere in the West, maybe at Texas back, and maybe at other places, but in the East Coast, so far, there's not. So let's see.
Yeah, we have a few people in our group that have got a one-level cervical at TBI. Those are kind of guys, you're right, that they're doing the training, and then we figured it was Dr. Landman. We've seen a little bit on, with him doing it. Have you tried the Active-L?
No, I have not.
Is it because nobody's ever approached you with it, or just weren't interested?
Yeah. Also, my feeling is that I'm a little picky moving to a new product. I try to be very conservative because I've done several hundred ProDiscs so far. Honestly, I haven't revised one of them. So it's kind of hard to beat. The Charité, I had some issues. After 5-6 years, I started seeing some arthritis in the facet. Not many. I've done 300 or 400, and I probably revised 4, 5, 6 maybe. Where a patient that develops severe fuse, and it's not a huge number, but see that I haven't seen that with ProDisc. So I am open to all the new discs, but I'm really I want a certain background and result in order to submit my patient to a new product. That's why I like this group, because I can share the experience of different patients and see how it goes, and
Sure.
And, that's a good thing. But I'm quite excited with the idea of using a disc which is more viscoelastic and makes more sense.
Sure. Yeah, I mean, we agree ball and socket seems a little odd at first, but you're right. You're very restricted here, and you have to go with the best product. Now, you use the Mobi C in the cervical, correct?
I use the Mobi C in the cervical. I still use it, actually. And I have a selected indication. I basically bounce from ProDisc to Mobi C based, and we can discuss later what the differential indication I have for these two discs, but I use both of them.
Yeah, because I mean, I want to give a shout out to Margot, who got us connected. You know, one of your patients that got, I think she had a 2-level Mobi C. With you. Yeah, correct. Yeah. And, you know, she's doing fantastic and really thought highly of you and really helped us bring us together. So thank you so much, Margot, for getting this done. So you've done some hybrids in the cervical as well?
I've done a fair amount of a hybrid on the cervical. And so I found that the hybrid have given me almost identical clinical result than the 2-level. And I've done more than 2-level. I've done 3-level hybrids, and I haven't seen any downside of doing this. And the hybrid, why would I do a hybrid rather than a multi-level? Many reasons. Sometimes one of the level does not qualify for an artificial disc. This is one reason. So we do a fusion at this level, but the other level are good cases. So put an artificial disc. Another reason is obviously, as you know, sometimes restriction of the FDA, and the insurance company in America are kind of following kind of closely the FDA recommendation, and they do not allow to do a 3-level, for example. So they only allow a 3-level fusion, which I think, honestly, unless it's absolutely necessary, is not a good operation, because a different reason. We will talk about it later. So in that case, I was able to negotiate in some cases to do a 1-level fusion and a 2-level artificial disc, even though it's not strictly in the FDA guideline, but it's easier to get this approved.
That's good. That's good. Who, let's briefly gather with the insurance companies. Who do you have more success with here? Because, you know, we've got people with United and Aetna's and the Cignas and all down the line. Who do you feel is easier and who do you feel is almost impossible? And we don't have to hit everyone, of course, because there's obviously so more, but maybe the big 4 or 5.
Believe it or not, the easiest to deal with are workers' comp. For some reason, you go to the board of workers' comp and you explain it's a worker's been injured, and you said if I do a 3-level fusion, no matter how successful I am, the guy would never go back to work in his previous work. As if I do an artificial disc and if the guy is motivated, then there's a chance he can go back to work. So if you do those peer-to-peer conversation, sometimes you convince them, and I'm pretty successful getting workers' comp board approve this procedure. Insurance company is a little more difficult. They tend to stick to strictly to the guideline, And I would say that probably the most difficult I've had so far have been United Healthcare. And also it depends. It depends sometimes, and it's very strange. Sometimes the same insurance company for two different patients, on one it goes very easily, for the other one, they give us a hard time and they put in blocks on roadblocks on everything we do. So I think it's a case-by-case basis. There's no general rule for insurance, and also from state to state, the insurance company are totally different. I had a Empire Blue Cross from Pennsylvania that approved, without any discussion, a 3-level, which was strange. When you do it in New York or New Jersey, it's a no. They don't even talk to you. So the same insurance. So it's a little, it varies.
Gotcha. Fair enough. Do you ask for a DEXA scan with your patients?
All right. We remember that the FDA guideline, for those who listen to us, maybe not American, maybe they don't know that. In all the FDA studies on artificial disc, osteoporosis and even osteopenia was a contraindication. But we have to understand one thing, is that when they say contraindication, they're not doctors, they're statisticians and they're engineers. It was not contraindication to treat the patient, it was contraindication to be included in the study so that they have a pure study. In real life, osteopenia is not a major issue. If you have severe osteoporosis, it could be, but osteopenia is not. Now, do I do a DEXA scan? I do it in patients who are at risk. For a female patient over 40, I think it's a good thing to do. And also, it's a good service to do because it's nice to do a screening and advise the patient how to treat their osteopenia before it becomes severe. For the male patient, it's less prominent, but there are risk factors, especially heavy smokers. And so I do it very often, but not systematically.
Do you, if a patient is a smoker, do you usually will not operate on them if they do not quit?
No, I do. Honestly, I haven't seen major problem with that. And maybe for fusion, I change it. I mean, we're not talking about fusion today, but that's what the risk is mostly. And for fusion, for example, I would change a little bit my way to approach the problem. For example, a patient who needs a fusion and is a heavy smoker, well, instead of doing just an anterior fusion, I would probably do an anterior and posterior fusion of the cervical or lumbar spine, when on a non-smoker, I would have done only an anterior. So I order a bone stimulator. So I take some extra precaution for the smokers, but I don't let them down because they're smokers. For artificial disc,
obviously for those reasons of what you just mentioned, we really try to have our patients really just quit and because we know the issues, you know, like you said, you have to get bone stimulators, you may have to get a posterior fusion, but I mean, that's fine. I mean, everybody has their issues and their non-issues. So, and it's good we're talking about this. So did you have anything else to say on it?
Yeah, because I answered your question for fusion, but I think we need to talk about artificial. And on artificial disc, in most artificial disc, we expect an integration of the metal, and this requires bone growth. And I assume that in heavy smokers, it should be a problem to get this integration. I haven't observed any specific problem on heavy smokers.
Gotcha. Yeah, it makes complete sense. Do you use bone wax?
First of all, I try to avoid leaving any raw surface of bone. Osteophytes, I try not to remove them, if possible, unless they're really, really huge. But I try to work around them and not resect them. And also, as you know, all the specialists know, I try to cover as much of the end plate as possible. So we're limited by the sizes available by the different companies. But if you cover as much as possible of the end plate, and if you don't resect the osteophytes, the risk of ossification is pretty low. But if I do expose some bone, I do use bone wax to try to avoid any ossification.
Fair enough. You do use a vascular surgeon, correct?
Yes, I was trained in France where I was doing my own approach. I practiced in France for 8-9 years before I came to this country, and I was doing my own approach. And so I came here, but everybody, you know, when you come to America, everybody scares you. Where are you going to be sick? So you should not do your approach. So I did my approach for a little while, and then I gave up. And I have a vascular. And you know what? After 20 years, it's not bad because, God forbid, I've never seen a serious vascular injury, but every time I see if something happened, it's here. For him, it's a 2-minute deal to fix it. If I was by myself, it would be a much bigger deal. So I'm used to it now, but I use a vascular surgeon, always the same one.
Great. I love your answer to this one, because a lot of surgeons don't really understand what exparel is right now for pain. So maybe you could talk a little bit about that. But this question was, what is your usual post-op pain control regimen approach? You gave me 5 answers, but like I said, the one is exparel treatment, which is something new, which maybe you can kind of explain why and how you use it, because I think a lot of folks have no idea what it is yet.
The anterior approach of the abdomen, to put an artificial or to do a fusion, whatever, is a very tricky, because if the patient experiences pain post-op, then we have to increase the dose of narcotics. By doing this, you slow down the bowels. The patient becomes bloated. And by becoming bloated, at distension of the abdomen, you increase the pain. It's a vicious circle that sometimes can lead to, in a few patients, but I've seen it, to occlusion and serious complication. By blocking the pain of the first 48 hours, you avoid this vicious circle. And I use that exparel which is a local anesthetic, a very powerful local anesthetic, and he has the advantage of lasting longer than the others. And by using this in the muscle, in the subcutaneous tissue, and just under the skin, the patient wakes up, did I have surgery? Yes, you had surgery. And it's artificial, of course, it's artificial. Because we know that 3-4 days later, I tell them, you're comfortable here, but the minute you go home, you're going to start feeling some pain. But at that time, the bowels started working again, they start having bowel sound, and it's over. They're not going to have the complications. So I think it's not only a question of comfort, I think it's a question of safety in terms of the bowel function.
No, it's fabulous, and you see it being used in knee surgery and shoulder surgery, and it keeps you opiate free, which I agree. And unfortunately, the folks in Europe, they don't have that approved yet, so we definitely have one up on them on this product. And basically, for those people that don't understand, when you go to the dentist, you get Novocaine or lidocaine, and this is basically one of those chemical ingredients that I think, how long does it last? It lasts like 3 days, right?
3 days. Yeah.
Which is amazing. And like you said, the patients are so much happier. And it's fantastic and I think it's only been out for about a year, I think 2 years.
Maybe a little more than a year and a half, 2 years. And obviously, yeah. And most of the patients, I don't use opioid. I send them home because we'll talk about this later. Maybe I give anti-inflammatory medication to avoid heterotopic ossification. And this is also help with the pain. And I give them some regular Tylenol and a little belt to hold the abdomen, but I try to not let them go with any OxyContin or any of these medications.
What do you give a patient that's had a hybrid post-op surgery?
It's the same, except that I don't give the patient anti-inflammatories because of the fusion. Now, the hybrid is a strange situation where the fusion cannot tolerate the anti-inflammatory, but the artificial disc is asking for it. So there's no way to do it. So either we take a chance of ossification of the artificial disc, or we take a chance of failure of the fusion. I decide usually not to use it.
That's a tough question. I know. I think you knew why I asked that one, because you have two going the opposite direction of what you want to do. What are your contraindications for artificial disc replacement?
My contraindications are spinal deformity. Although if you have a thoracic scoliosis, it has nothing to do with an L5-S1 disc. I'm talking about deformity at the level where you are doing the surgery. If you have a lumbar scoliosis with a tilted L4, L5, and with pain at this level, I don't think it's a good idea to insert it. And it's a no-no for the FDA anyway, so we have no choice. If you have a deformity of thoracic spine, like a thoracic scoliosis, and the patient comes for L5-S1 degenerative disc, even though I think if you go strictly by the guideline of the FDA, you should not do an artificial disc. I think if the lumbar spine is perfectly straight, I think there's no problem using it, honestly. Spondylolisthesis, it's when for those who don't know, it's when one vertebra slips over the other one and causing nerve compression. It's a tricky situation because there are two types of spondylolisthesis. The spondylolisthesis that are structural. You have a real slippage of the one vertebra over the other, and it's kind of fixed. And this is due mostly to a failure of the posterior facet. In these cases, I think it's a contraindication for artificial disc. However, you will see some very small spondylolisthesis where it's not a failure of the facet at all. It's only because of this collapse, and basically all the ligament became loose, and basically one vertebra that slips a little bit over the other one. It's a grade 1 spondylolisthesis with kind of almost normal facets. In this case, if you restore the height, you're going to reduce the spondylolisthesis. And in these cases, I've done it, and it works very well.
What about for mild degenerative scoliosis? You know, say we see that the discs, for whatever reason, are failing more on one side or another, and creating that scoliosis. Will you try it there?
No.
Okay.
No, because I don't have enough argument to think that it's safe for the patient. Also, I live in an environment, a very litigious environment. It's difficult, you know, especially you're in New York, to kind of experiment on a patient. I mean, I'm not sure this is the right thing to do, so I don't do it. Now, okay, if some other people have a large volume and are ready to try, I'm sure there are cases that could be handled properly.
Okay. This is more getting back to the distraction pain. We see a lot of our patients have a lot of distraction pain and it never makes sense to us. And I'm sure you probably say that to some of your patients as well. You know, we'll see somebody with a one level, say L4, L5, or L5S1, and they barely have any disc degeneration, but they have say they have a hernia and it's on the nerve, and you know, you clean it out and there's still a large amount of distraction pain running down the legs. And then you have a patient that had a 3 level and they were bone on bone and you know, major distraction, and they don't have any nerve pain going down the legs after post-op. Is there, you know, that's probably one of the questions that we really have a hard time trying to figure out. Do you have any rhyme or reason to why that is, why that occurs?
All right. I'm not sure I have the right answer, but what you're saying suggests to me that if you take a disc that's still high and just a disc herniation, patient with chronic back pain, and assuming we decide that this is a good case for an artificial disc, you remove the disc, the space is still open, but then you need to fit this artificial disc, and you want to make sure it's going to stay there. It's not going to come out the minute the patient gets up. So you tend to over-distract to make sure to have a good fixation. By over-distracting, you bring the level beyond the physiological and you might very well pull on the nerve, especially if the patient had a discectomy before. If the patient had a discectomy before, which is often the case when you do an artificial disc, then the nerve is trapped into scar tissue, and then you over-distract it, and you're pulling on that nerve, which cannot go anywhere, it's stuck with the scar tissue. So that's a situation. When you take a completely collapsed disc and you put it back to a normal situation, basically you're restoring the normal height, you're not over-distracted. And the nerve in the back, even with some scar tissue, are much more comfortable. So the high disc is more tricky than the collapsed disc in that sense.
You know, that's a fantastic answer. I never really, out of all these interviews, no one's ever kind of gave me that analogy, and I think you really have something there. I never,
because after all, just to add something to that, when you take a collapsed disc and you reopen the natural, before you put the disc, you look at it, the natural tendency of this collapsed disc after you remove it is to come back home. So you have to keep it open to insert it. When the disc is there, there's a lot of pressure on the disc. So the disc is immediately stable. You don't need to over-distract. And it's probably safer, actually.
I said, you tickled my mind on that answer. Have you had any irreversible complications after artificial disc replacement?
Irreversible, well, the 5 or 6 cases of patients who had a facet arthritis 5-10 years after a Charité, and I fused them, irreversible in a sense. I mean, but it's not life-threatening, but it's irreversible. I had to fuse them. I had one case I put an artificial a long time ago, probably at the very beginning, and the next day I took an X-ray and I didn't like it. I didn't like it. I talked to the patient, and I brought the patient back, and unfortunately, there was no other way but doing a fusion at this level. That was a very special case. Other than that, I never had any vascular injury in the neck. I never had any neurological injury, esophageal injury.
Oh, sure.
And one of the complications in the neck, of course, just like fusion, is to have a lesion of the recurrent laryngeal nerve, which are not good. I never had. No, I'm fine. I had some complication, like everybody. When you do 1,000 cases, you always have complication. Actually, I like to say that whatever you do in life 1,000 times, you're going to have problems once in a while. I think especially at the beginning of my experience, I was maybe a little too liberal in my indication. Patient was begging me for an artificial disc, and I was thinking I might not be a great case. And I've tried to please the patient, and I regretted it after that. That made my mistakes at the beginning. I'm becoming a little tougher as I get older, and I follow and I try to convince the patient that honestly, your case is borderline. A good fusion is better than a bad artificial disc. And I, if you take the time, patient understand, not everybody, but it's fine. And I can tell a story here, for example, without using any name, of course. I saw a patient many years ago, and he didn't qualify. He had a very large laminectomy before. more than half of the facet was gone on one side, and a third of the facet was gone on the other side. The disc was totally tilted. And I said, you cannot have an artificial disc. And he said, oh, I don't want a fusion, I don't want a fusion. Okay, fine. But why don't we do a CAT scan? And because I don't need an MRI, why don't we do a CAT scan? I can measure exactly how much bone has been lost with this laminectomy and see if it's reasonable. He said, okay, I gave him a prescription, never came back. He came back a year or two later. He went somewhere outside the country, and he had a 2-level artificial disc, which was a complete disaster, and it completely collapsed. And that confirmed me that it's not a good idea to get out of your comfort level. If you, as a specialist, especially if you have a vast experience, if you feel that this case is, if you feel that you wouldn't do an artificial disc if it was your brother or somebody in your family, maybe you should not do it. There's a limit of what you can do. This is my take on it.
No, and I agree, and I think it all kind of relates to what you have to use as well that's approved by the FDA. You know, the viscoelastic, as we know, is a little bit more stiff and a little bit more closer to what I call it a soft fusion. And because of that, I think your limitations are much more larger. You know, the patient may not have as much mobility, and that's kind of definitely up in the air. But you know, because the ESP that you're familiar with is so rigid that, you know, you definitely have much more availability on, you know, treating more patients. Hey, getting into the next thing, I see something that I like as well, and I'm going to put the two questions together. What do you do to prevent adhesions and scar tissue from forming? Because I think both those are kind of related together. And you mentioned amniotic membrane, and how long you've been using that, and what do you think, how much do you think it helps?
First of all, there are many aspects to your question. Scar tissue is avoidable because it's a part of the healing process. I mean, if you cut your skin and it heals, you have a scar. You cannot avoid this. The problem in what we're talking about, artificial disc, is the adherence of vital structure, like the vessel, mostly in the lumbar spine, but also in the neck with the esophagus, to the spine. And if you need to go back, then you're taking a risk. And in the lumbar spine, it could be a life-threatening risk. So to try to find a way to separate, we cannot prevent the scar, but we can separate the scar from the spine by interposition of a membrane. And that's a fantastic idea. So recently, I've started using, quite recently actually, amniotic membrane, because it's been shown that it helped not prevent the scarring, but basically to separate the scarring from the vessel from the scarring of the spine. So if you have to go back, it's easy to separate those two structures. It might be a fairy tale because we don't know for sure. Thank God we rarely go back. We rarely go back. So we can use like 100 times an amniotic membrane without actually knowing if it worked. We're not going to reopen the patient to know if it worked. And we don't want to, we'd rather not. So I use it, but I don't know if it works. I don't know if it works. I didn't have a chance to reoperate a patient that I used the amniotic membrane on so far.
Yeah, it'd be interesting if you ever do. I mean, hopefully you never do. And, you know, that's first and foremost. But, you know, if it does, I'm kind of a believer that the chemistry behind it kind of makes sense. At one point, about 3-4 years ago, I sold an amniotic membrane. We really promoted it more towards like tarsal tunnel. And those who are not familiar with what tarsal tunnel is, it's the carpal tunnel basically that goes along your ankle line. And the revision on that is you know, the revision success is about 20% because it adheres so much scar tissue and gets on that nerve. And we used it on that, and the podiatrists and orthopedic foot doctors said it worked fantastic. So going through that same background, if it's going to work there, why wouldn't it work in other applications? That's where I kind of thought, and those guys would know, you know what I mean? And those, you know, if they didn't have any revisions and they knew that it worked, because it prevented from scar tissue from happening and those adhesions from happening. So I kind of am on board with it, is why, like I told you, it seemed to work there. And like I said, it's hard to tell more so in spine.
The other thing, I'm sorry to interrupt you.
Please,
Just
no.
to finish about the scar tissue, in the cervical spine, it's not such a big deal. To a revision approach, it's not so difficult. In the lumbar spine, it is. And one of the tricks that we use sometimes is when we do an L5S1, whether it's a fusion or not, is to use a right side approach. So instead of going through retroperitoneal to the left, we go retroperitoneal to the right. That if especially with fusion, because we're worried about the adjacent level problem. So if in the future we need to go back, we can always do a left side approach for the S05. It helps a little bit. It doesn't make a terrible difference because we're not so much concerned about the adherence of the peritoneal to the abdominal wall. We're concerned about the adherence on the spine of the vessel. So whether you go to the right or to the left, at the end you get to the spine, you have the same adherence. So it doesn't make a huge difference, but it's a popular way. A lot of surgeons do that with the hope of helping the revision surgeon.
Fantastic. What are your follow-up requirements? Patient comes in, gets a hybrid, multi-level, I'm sure everybody's kind of the same. So, and I know you treat patients across the country, California and Montana, wherever, you'll obviously see those patients. And, I don't know if there's any patients, Canada, we talk about Canada a lot in the group, and they're further behind than we are. And I know a lot of patients are afraid to travel on a plane and afraid to go overseas. But would you entertain doing a Canadian patient or international patient as well?
So my routine follow-up is I see the patient 1 week after the operation.
Okay.
Cervical are often done as an outpatient.
Sure.
Lumbar not. We like to keep them a day or two. And then I see them a week or 10 days later, just make sure there's no local problem. As everybody knows, for some very strange reason, I've never seen or heard of an infection on an anterior approach. It sounds in terms of infection, it seems to be a super, even when I do fusion, I do anterior more often than posterior. There's no infection, but I still see the patient after 1 week, make sure they're okay, the swallowing, everything. And then I see them at 6 weeks. I take some x-rays, make sure everything is good. Then my next follow-up is 3 months and then a year. Now, for patients who live far away, it's kind of difficult. I like to joke with them. I said, I can come and visit you. So by doing this, I will visit all the state of the country and maybe do some sightseeing. Most of the time, I've done it actually. I've done it. And that's the only time I went to Alaska is actually to see a patient, and I combine it with a vacation, and but I cannot do that all the time. Most of the time, everything can be handled by phone, by internet, like we're doing right now. And I asked them to send me X-ray. They all have my cell phone number, so if they have any problem, they call me. And I like to have, which is not always possible, I like to have a local spine surgeon who would be ready to collaborate in case of a complication. Sometimes they are very nice and they collaborate with me. Sometimes they don't. And I can understand why. But never had an issue with it.
I'll touch on this subject as well. We talked about it in the pre-meeting. You would entertain patients that have gone to Europe with failures or follow-up as well, correct?
Yes, I do.
And then you already talked about some revisions that you've done, and I guess maybe you can kind of give a couple examples of some of the revisions. And you talked, pre-meeting that you would like to, and please give me your answer over again, like how you talked about. And I'll just let you answer what you would do as far as revision on 1 or 2 level, and what scenarios you would try to to create for that patient?
Revision, initial surgery are kind of standard. I try to, all my cases are similar. Revision are always a unique experience. They're not two cases exactly similar. And I did a few patients from the group already. And recently I did one of the patients of the group, which might be watching now. And she had a 2-level Mobi C somewhere in Europe. And the Mobi C is not a bad prosthesis, it's a good one. However, as I like to say, and I talk about it with Margot very often, it's less forgiving. If you place it at the wrong place, if you put it at the wrong place, or if you don't do, and maybe we can talk about this later because this is extremely important. If you don't do a posterior release of the space, then this prosthesis can migrate. And that's a problem. And this poor lady had a 2-level Mobi C, and each one migrated in different direction. So that was unfortunate. And so we revised her, and she's happy now. We revised her with 2 artificial discs. I put 2 ProDisc on. The bone was healthy, all the space was fine. And I think the problem is the surgeon did not clean enough the posterior part. And if you want, I can say something about this. When you have a collapsed disc and you want to reopen it, coming from the front, when you start opening the disc, this is what's going to happen. You're opening the front, you think it's a good space, but it's still stuck in the back. And if you put a prosthesis in this position, the minute the patient starts moving, the prosthesis comes out. What you have to do, you really have to open the back and have a parallel opening of the space, which is not always easy. It requires a lot of effort, and I think it's essential. If you don't do that, you have 2 problems. If you don't do that, you have 2 problems. You're like this, the disc can come out. But the other problem you have, by opening the front, you're closing the foramen in the back, and the patient has severe radicular pain. You really need to do whatever you can to open the disc this way, so the disc is stable and the foramen is open.
We have seen a few patients in the last 6 months get Mobi Cs and exactly what you're talking about. They don't put them far back, and sometimes we've seen the post-op X-ray. We're talking, a day later, and they've already migrated, and it's a shame because you would think this. I mean, I would think if I was that first person, I would try to fix it because it's clinically looking at the X-rays. There's a major issue going on, but and then they come to our group and they're like, "Hey, does this look right to you?" And sometimes I don't even have the heart to say it because I'm just like, here you're going through all this and it's tough, and we see a lot of that here in the United States as well. But okay, great answer once again.
I can add something on this Mobi C, is that the normal shape of the inferior end plate of the vertebrae is normally concave. And the Mobi C adjusts perfectly to this concavity by being slightly convex. So when you put it in place, it locks in, and if you do the good posterior release, it shouldn't go anywhere. Unfortunately, part of the degenerative process is that in many patients, the bone becomes flat gradually over the years. And if you put the Mobi C, which is convex, basically the point of contact is very limited. You don't have this ball and socket type of contact between the bone and the end, and that contributes to sometimes the instability. So that's why I said that at the beginning, I use Mobi C or ProDisc. When I have a very good concavity on the end plate, then I tend to use the Mobi C. I like it's a good product. If the end plate is totally flat, I know that the Mobi C is going to be unstable all of a sudden. So I'd rather use the ProDisc.
Interesting.
Let's see what the M6 shows, because M6 I have no experience so far.
I was wondering is maybe in 6 months we kind of do a recap and give us your thoughts on the M6, and see what you think. I know a lot of patients are excited about it. And then, obviously we've got a lot of patients in our group that got, and not so much the C's, but the L's. And you know, between you and I, there's been quite a few revisions, and we don't know if it's from orthofix and changing the engineering on it, or not so much changing the engineering on it, but maybe changing how they build it, because we've seen, you know, some of it collapse, and that was internal, you know, there's that nylon cord and some of those things kind of failing. So it'll be interesting to see, you know, when I went to ISASS in Toronto last year, you know, there was fellows in there from Portugal and all over doing 4 and 5 level M6C, and have patients 7, 8 years out, and the patients are doing fantastic. And you know, he's got X-rays at 1 year, 3 years, and 6 years, and it was quite remarkable. So I think there is a lot of hope with the M6C because of the, you know, the not being so much force in the lumbar that you would have. So I have a patient here that just had a couple ProDisc put in by Dr. Bertinoli, and I'm sure you're familiar with Bertinoli as well. What are your thoughts on the semi-constrained design of the ProDisc? Is it held together only by tension between the vertebrae? If so, what are his thoughts on axial traction therapy, inversion tables once healing is done? So you know, he wants to do like maybe that teeter hang-ups or going upside down. Do you think that's possible with that disc?
So first of all, I know Bertagnoli. We are friendly. We're supposed to, it didn't happen. We're supposed to go on a motorcycle trip together.
Oh, wow.
Yeah, because I ride motorcycle and he does too. And we're supposed to do that at the SRS in Italy last year, and I couldn't go last minute. I had a conflict. I had lunch with him, and we were kind of friendly. And he's a fantastic surgeon, surgeon. And I have a lot of respect for him. And I've seen his cases. And one day he was in New York. He showed me his cases, like 5 level. Being in New York sounds like a little crazy to me, but the placement was absolutely perfect. Every level, every time. That was very impressive. Very impressive. I cannot do that in New York. That would be a big riot. But no, I know him well. The ProDisc, I've been using a lot of ProDisc, and I understand the. First of all, as I mentioned, I haven't seen the facet arthritis that I've seen with the Charité, but in all honesty, I haven't done as many ProDisc as Charité, and mostly cervical. On the lumbar spine, I don't have statistically, I haven't seen any posterior facet problem, but is it only because I haven't done enough, or is it because it's better? I don't know. The keel, always been a big question about the ProDisc, and with the risk of this, and maybe we'll talk about this, and I have my own opinion about this. And I think, anyway, to answer the question, the fact that the ProDisc is more constrained than the Charité is probably a big improvement. I think the problem we had with the Charité is the hypermobility in rotation, which was in some patients really damages the facet seriously. I think the ProDisc is better in that sense, and if you want, you can ask me a question about the keel, because I'm kind of prepared for that.
Well, you know, the M6 actually has some very large keels as well, and you know, obviously that makes your patient selection a little bit different as well if they have really soft bone, and then, you know, the worry is when you do the revision on the keels, you know, getting that out of there. I think that's going to be always the worry. You know, with the ProDisc, the technique is nice where you could just replace the core. Have you ever replaced the core on a ProDisc?
No, I never revised any ProDisc so far.
Do you think you eventually will?
Well, some patients are very young. So when they're 30 years old, and I don't know if the ProDisc is going to be able to last 60 years, sure. But by then I will be retired, and I might not be the one revising them, but they might need something at some point. Sure. Nothing lasts forever. As far as the revision, I revised a few Charité, and the way I revised them, I don't know if other people do that. because to go back anterior to remove them, it's scary. No matter how good your vascular surgeon is, it's very scary, especially when you remove the disc with those teeth, very sharp teeth. I mean, it's very easy to rip off the vein and then that become a disaster. The way I revised my charité was using an X-tooth approach, a lateral approach through the psoas, just like we do a lateral fusion.
Sure.
And it's amazingly easy. Obviously, with a ProDisc, it's almost impossible because you have the keel. So I'm a little worried with the ProDisc, if one day I have to remove one of them, that would be a big production because you have to go back anteriorly. You cannot do it from the side unless you do a complete corpectomy, which makes no sense. So as far as revision, I never did a ProDisc. I never revised a ProDisc, and I'm not anxious to do it.
Have you seen the Axiomed Freedom Disc yet?
No.
That they're not getting approval, I think, anywhere. And I probably shouldn't say this, but from what I've learned, and they've been trying in the EU for quite some time. But they have a lateral approach that they're really working on, which I think is a fantastic idea. But they have very large keels as well, and I don't know how. I mean, going from a lateral approach or an oblique lateral approach, that space you have is so small, especially to try to insert something with large teeth. I don't know how that would work, with a device like a Charité or an ESP, not to say we use a Charité again, but say an ESP where their keels are very small. I think it would be much, much easier to do, a lateral approach. But what are your thoughts on that?
I think the idea of putting an artificial disc from a lateral approach, it's a great idea. And I've been talking about this to different companies for many years. And there are different problems with this. Number one is the amount of discectomy you can do without destroying totally the psoas muscle. And in order to be able to do what I spoke about earlier, the posterior relief. If your disc is very collapsed, it could be hard to open the back from the lateral approach. And we're going through the psoas. So going through the psoas, you have a risk of injuring the nerve if you distract too much. So that would be a limitation. And the other limitation is the coverage of the end plate. From the lateral approach, you're limited to like 18 millimeters, 22 millimeters. But in order to cover the whole, the entire end plate could be a technical challenge. I don't know, maybe putting something from the side and something expandable, if it's possible in the future, maybe. On the other hand, that would solve a lot of problems because now you have one level, you want to do the next level a few years later, that wouldn't be an issue because you have no scar tissue, no problem with the vessel. That would be a dream if it really worked.
Agreed. Do you see any chance in the future, and I guess this can go more with a lateral approach, where the ALL can be preserved or reconstructed?
When I was trained in France with Thierry David, we used to never take the anterior annulus. The way we used to do it was very cumbersome. We used to cut the annulus only, and we were leaving a hinge on one side. We attach it somewhere, we do artificial, and then we will resuture the annulus and do a reconstruction of the anterior annulus, anterior longitudinal ligament at the end of the procedure. I think everybody has stopped doing this for different reasons. First, most people think it's not necessary, and also for technical reason. When you keep a hinge, it becomes very difficult to efficiently retract the vessel. So I've heard of vascular injury due to the fact that the retractor was blocked by the hinge of the annulus and couldn't really retract the vein all the way. So to take a vascular chance for something we're not sure is really useful, I think most people stop doing this.
They did, yeah. Mostly everybody we talk to, yeah, for sure. I don't know
That
anybody.
that was the initial technique. That was I was trained to do at the beginning.
Yeah, yeah. Okay. Given that the cervical spine and the pelvis are key compensators for improper sagittal balance, the PLL ratio correlates with changes in quality of life, and radiographs of cervical, thoracic, and lumbar spine insufficient to assess sagittal balance. Why are more patients required to get an EOS scan? Do you know what an EOS scan is?
Yeah.
I figured you would, being from France. It's big over there, but United States, they're mostly using it in pediatric, which I know you do some pediatric scoliosis as well, but so I guess why some more decisions looked at that, trying to, create the most sagittal balance throughout the spine. Do you use EOS?
Yes.
Quite a bit?
Yeah, we don't have it at Lenox Hill, but in New York City, there are two of them, one at NYU, one at Special Surgery, and I use them routinely. And I would say, always been my impression that artificial disc is superior to fusion in most patients, not because of the 5 degrees or 7 degrees of flexion extension. It doesn't make a big difference, especially when you bend forward to pick up a pen on the floor. Most of the motion occurs in the hips, more than the lumbar spine. So the 5-7 degree of motion at L5, S1, L4, what difference does that make? I think the main difference is that when you do a fusion, you put a patient on the table and you fix the patient in the position that he's in. An artificial disc, you put the artificial disc and then the patient stands up and automatically the spine rebalances to the right position in the 5-7 degree of motion. And if you look geometrically, 5-7 degree in the L5-S1, it's a lot of big angle if you look at the whole body. And the patient can easily compensate. And I did a study a long time ago, and I looked at my Charité. I've reviewed 50 cases of Charité and I compared the X-ray on the operating table at the end of the case, and then at the visit when the patient was standing. And it was amazing that all cases, you put it in certain position, the patient stands automatically, the patient rebalance in this artificial disc. And there was a big difference between the standing X-ray and the operating X-ray. The fusion cannot do that. So when the patient stands after this compensation has to occur in another. And that's probably a big factor of adjacent level problem, is that you cannot expect on the operating table to always give a very functional position.
Yeah. Since facet degeneration continues to play a critical role in pain generation post-ADR for many patients, how do you evaluate the facets, and what is your criteria for disqualifying a patient on this basis?
Okay, facets. If the patient had a laminectomy before, it's important to make sure that the facet was not totally or substantially removed, like the case I was talking about earlier. In that case, it's a problem. Until we have a replacement that we can use at the same time, it's a problem, and I don't think the artificial disc is indicated. As far as regular degeneration of a facet, there is always some degree of degeneration of the facet. You cannot have on a degenerative disc a 100% normal facet. So how do you evaluate? At some point, it's a judgment call, and I look at the facet. I always get a CAT scan, see, and my criteria on the CAT scan is actually what Paul McAfee taught me from Baltimore, is that basically, as long as the end plate of the facet are parallel and there's a space, even if it's a little narrow, even if it's a little arthritic, it's okay. The problem is when the end plate, the articular surface are becoming irregular. So it's clear that now restoring motion might be tricky, might be a little dangerous, because you're gonna you're gonna remobilize some joints that are not congruent. However, over the years, I've seen less and less, I've been less and less rigid about this indication. And I don't think the facet most of the time are a big problem. In what I've done, I use a CAT scan. If I really have a big doubt, I can use a facet block. And I haven't seen many cases, I cannot even remember, where, I cannot remember one where I regretted putting the artificial disc because the patient developed facet pain right away. The only case I mentioned earlier was a patient who developed facet pain 5–10 years later because the hypermobility of the disc. That's another story. But I don't think the facet is as much a big deal that we thought about when I started. And the FDA at the beginning had this restriction that facet arthritis should be a contraindication. So basically, if that is the case, you can only do herniated disc. You cannot do degenerative disc, basically, because you always have some facet arthritis. And there is this discussion between the ball and socket disc compared to the viscoelastic disc. And I understand, although I have no experience personally, that a viscoelastic disc where the motion is like this can be much more tolerant of facet arthritis than a ball and socket can mobilize the facet much more. But that I don't know. That's
many patients have specific positional pain which isn't triggered in supine. In such cases, how would you rate the diagnostic value of upright and functional flexion extension MRIs? Did I lose you? My signal? All right, we had a little technical difficulties, but we are back. I got 2 more questions left. Much has been written about semi-constrained ball and socket versus elastic prosthesis. In particular, there's a debate about the following topics: center of rotation, sagittal translation, axial rotation, and cushioning. What is your view on these topics? And how each design addresses them? Feel free to discuss durability. And you said you haven't obviously had any issues with the ProDisc, which is fantastic. And just your overall thoughts, and you're familiar with the ESP and some of the other things that are out there. So,
all right. As you know, the ESP was kind of developed in Paris, and by some surgeon who was the same generation as me. So we were resident together. And we've been on the phone many times, and I know them well. And in preparation for this discussion, I called them at La Pitié Hospital in Paris, and have a little bit what they feel about it. Of course, they're the promoter, they created it, so of course they're promoting their baby. But first of all, I want to say that these people are extremely serious people. I trust them. On the other hand, this is a new product, and we always have to be a little careful. We've seen new product which was supposed to be fantastic and gradually disappear from the market for different reasons. And I'm thinking about the Brian disc that was it came to the market in the US and kind of disappeared. So we have to be careful about new novelties, and we have to remain critical. However, the concept of a viscoelastic disc is very very attractive, because everybody knows that no matter how happy I'm with the product, it is true that this ball and socket is not physiological. I want to make an analogy. In hip arthritis, there was a big hype at some point about, instead of removing the whole head of the hip and to do a resurfacing and say, we're gonna respect the normal anatomy and stop doing artificial hips and do a resurfacing. And this didn't work. Sometimes you want to recreate something that's physiological in an environment that is not physiological. And we have to be careful that a good idea might not be the right solution sometimes. So I'm keeping my eyes open. So they explained to me that it's going to take some time for the ESP to come to the market. The one thing I noticed, the viscoelasticity makes sense. The thing they said is, and it's the same thing for other discs without the keel. There's a big concern about the keel part. And the concern is not only for multi-level, even for single level. And this is what I have to say. One, you put an artificial disc. You want this disc to be solidly anchored. You don't want it to be to be displaced after surgery, especially in the lumbar spine. It could be life-threatening. And I want to say that when I put my ProDisc, this ProDisc will not go anywhere. Almost guaranteed. If you place it properly, it's staying there, not moving. As opposed to other discs with like the Charité, for example. But even for I spoke with the surgeon in Paris, and he said, well, when we put our disc, we ask the patient to limit their activities the first 6 weeks. We put a little belt on them until the integration started. And that doesn't make a lot of sense to me. If you take a knee replacement, for example, you take a knee stiff and you have to do a release in order to recreate the mobility of this knee. You put a knee replacement, immediately in the recovery room, they start mobilizing the knee. If you tell the patient, don't move for 6 weeks, the knee will be totally stiff. It will be a failure. To do that with artificial disc, especially in a disc very collapsed, where you have to release and to recreate the motion to restrict the patient, the first 6 weeks makes no sense to me. And I share that with them. With the ProDisc, because of this skill that people kind of criticize a little bit, it's so solidly anchored. I mean, if the patient wants to go to the gym a week later, I have no problem with that. They can do hyperextension, they can do hyperflexion. And I think this is critical. The first 6 weeks are critical in terms of activity in order to maintain and to guarantee a long-term range of motion of this disc. That's what I want to say about it. As far as the viscoelasticity, I do not know. It sounds like a fantastic idea. Is it going to make a difference? I don't know.
It's a very good point. You know what I mean? That a lot of these fellows in Europe, you know, they're putting them in belts, like you said, and you know, but some are still doing. You know, it's a mixed bag. Some people say, hey, don't do anything, and some people. But I definitely agree to your point that you need to keep moving. You need to stay physical, because the essence is you create that blood flow. You know what I mean? When you sit, you don't have blood flow, and that's why everybody says you got to walk, you got to do this and that. And I think you hit on a good subject there as well. Last question, and this is kind of, I guess I want to explain two different situations before, maybe two different patients. Patient A has radicular pain, but you look at the desk, it has a lot of moisture on the MRI. Very little herniation. Patient 2 has L4, L5. The disc is completely black, and you know, almost bone on bone. What is your thoughts on a discogram for both patients, or is it the same for both?
The question is about the discogram?
Yeah, because we had a patient come in last night talking about his doctor wants to do a discogram on L4, L5, and his L4, L5 is shot. And I don't know why anybody would want to inject dye into that. I don't understand why people would want to inject, this is just my opinion, why anybody inject dye into a healthy disc as well. I mean, I understand you want to see where the pain indicator is coming from, but a lot of times I feel on images between MRI, CT, and everything else, you should have a good idea where the pain is and from the patient's symptoms. So, you know, my jury's kind of out on a discogram, but, you know, I wanted to get your thoughts. Okay. Do you order it? And the other part of it is, and maybe we'll talk a little bit more about insurance. I said, you know, I think to me, it's just a step for the insurance to get some, you know, you have to create all those steps. You have to do conservative therapy, and then you do injections, and, you know, the insurance, what they require. And I don't know if a discogram helps in your appeal to say, okay, I want to fuse, or I want to do an artificial disc, if that's another good step to have in your your suitcase.
Okay, the discogram. The discogram was a requirement in the FDA trials. A patient, in order to be included in the study, needed to have a discogram. And we did a lot of discograms. Number one is kind of a barbaric test. I mean, it's extremely painful. Patient is the worst memory of the patient at that time was the discogram, was not the surgery. That's the first thing. Number two, in order to have a meaningful discogram, you need to have a control level. Just having a disc that's painful during injection is not enough. You need to have another disc that's normal, that you inject and does not create pain, which is a problem because it's been shown in experimental models that injecting a normal disc can trigger the degeneration of the disc. So it's not an ethical thing to do anymore, and I don't do it anymore. I have a very little indication for discogram. And when I do it, rarely, when I do it, I don't do a control disc. I use another technique that I think was described by the Koreans, which they call the disco block, which means you get a control without injecting another disc. You do your discogram, the patient has the pain, but then what you do, you inject on the same disc through the same needle, a local anesthetic. And you see if that works. If the pain disappears, then you have your control in the same disc without putting a needle in a healthy. And this disco block works very well. However, my indications are getting very rare now. As you said, with all the technique we have now, we have a good idea of which disc is painful.
Yeah, I mean, I think you used the perfect word, barbaric. I mean, I think it is kind of barbaric to a point. You know, you make these patients suffer, and they're already suffering. So I think that was a good explanation, and I'm glad. You know, we've been on the same page with everything. I'm glad we're on the same page with that. Insurance, you know, in the United States, I always tell people, and this isn't really talked about lengthy enough in the group, but a surgeon in the U.S. will get, you know, almost twice the amount on a fusion as they would as an artificial disc. Would you not agree?
That's kind of a politically incorrect question, but
it is.
But I'm telling you, I was saying at the beginning of the interview that I trained probably 2,000 or 3,000 surgeons with a Charité at the beginning, and very few of these surgeons actually use artificial disc. They came to training, it's interesting, but they don't do it. And the reason is, there are many reasons. First, it's sometimes a little difficult to get approval because it's a lot of administrative work. You have to submit, they refuse, then you have to do an appeal. Then you have to spend time over the phone with one of their doctors. And it's very cumbersome. When if you do a fusion, you just do a fusion and it takes 2 minutes. So that's number one. Number two, you're right. When I do a fusion, I get paid almost twice as much as an artificial disc. So we can understand that it's it's a big problem, you know, for the development of this artificial disc and of this technology, that basically we have to require the surgeon to do an operation that's more difficult. Because a fusion, you put the bone wherever you want. As long as it heals, it's a fusion. It doesn't matter. The disc has to be perfectly placed. You have to do it under fluoroscopy. Fusion, you don't use fluoroscopy. So there's a radiation involved. It's very difficult. If you don't do it perfectly, we've seen what's happening with the Mobi C. You got the displacement, your complication post-op. It's much easier to do. And you get paid twice. So who wouldn't do it? Well, it's a human problem.
I knew these answers for a long time, but you know, a lot of people, I don't have the credentials that you do, so it's always nice when someone's honest and candid to the politically incorrect questions. I guess last and follow up, is there anything that you want to talk to about the group as far as your patient care, what your direction is, and what do you think the direction is in the United States with spine? Anything else you just want to kind of elaborate on? I'm giving you this free time.
I got the question. If you don't mind, I'm going to finish on the previous one.
Sure.
Politically incorrect. The fact that some surgeons decide not to reduce their income, increase their headache, I can understand it. It's a human reaction. And they do what they like to do, and they get, that's understandable. What is not understandable, and I'm going to be even more politically incorrect than you are, is that the centers that advertise artificial disc only to attract patients, and when the patient is in, they almost systematically do a fusion. And so they always find a contraindication somewhere. And you just take the FDA list, for example, they have like 75 contraindications, which was not to artificial disc again. This was contraindication to be into the study. And they use this as an argument. And I know some centers, they rarely do one artificial disc, but they advertise artificial disc center. This is not something that is acceptable. That I don't like it. That's what I wanted to make it this clear. And your question was, this last question was?
It's just anything you want to elaborate on that about yourself, about your office, anything you want to just kind of tell us, you know, how you do things. If you know, say for example, someone from California or New York, you know, wait times to see you, or I mean, and this may fluctuate, of course. You know, summer you may be busier than winter, and vice versa. You know, if a patient wants, say patient from Wisconsin, there's not an artificial disc surgeon around anywhere near them. They live out in the boonies, but they'd really like to interview, and that's what we're trying to do. We're trying to promote you within, and they want to come see you. What do you? And of course, the things we always tell them: we want a DEXA scan, we want an MRI. We would like to have a CT scan. What are the requirements that you will engage in a conversation with them, you know, through via email at first, and then you say, okay, I want to see you after that. What is your procedures? That way people will know, because what we're trying to do is make things easier for you as well. That way, you know, your office isn't requesting things. You're not requesting things. It's a one and done. Here's my evaluation. Here's what I'm suggesting. Next step is you fly to Manhattan, and then I'll see you there for an evaluation. But you know, where do they start? Where do they end, and so forth?
First of all, I have a lot of experience on this because, as you can imagine, I was one of the first artificial disc surgeons in the country. At that time, patients were flying from all over the place. It's not necessarily the case now, because there are surgeons who are doing artificial disc a little bit everywhere. But at the beginning, we were only 10 of us in the whole country, and basically we were sharing all the patients. So I have a pretty good organization for this. The first thing is, whenever I receive a request, I try to evaluate the patient over the phone personally. I don't use a PA, I don't use a nurse, I just do it myself. I call the patient, try to get the story, try to get some x-ray, and I try to, especially if patients live very far away, I I try to make sure that I have an argument that the patient is a good candidate for artificial disc. If I think the patient it would be better served with a fusion, I just suggest that maybe he should stay locally and
Sure.
find a local surgeon. So I try to go as far as possible. Then at some point I need to see the patient. So we try to do like a package. We don't do like in Germany where it's like a Club Med where everything is included. No, I don't do that. However, I try to make arrangement with my office. I see them, for example, on a Thursday. I make them come, for example, on a Tuesday, and I organize whatever I need. A new MRI, a CAT scan, a facet block, whatever I think is appropriate. And I see them on a Thursday. And if everything works, and if the patient is a good candidate, is willing to do it, basically I keep the patient over the weekend and I do the surgery the following week. So it's one trip for the patient. Sometimes the patient don't agree with that. They want to see me and they want to go home, think about it, which is fine. The patient who's reluctant to go back and forth twice, like this patient from Alaska, it's not that easy to come. Then we try to do everything in one setting, in 1 week, basically.
Okay, fantastic. Hey, one last question. I ask every person this. We see a large occurrence of SI joint pain with patients that get hybrids and also full, artificial disc replacement. What do you do to kind of, I mean, we know there's tests. Do you do the lidocaine to kind of see if that eliminates the pain or injection? What are your steps to kind of follow that? And what do you do to, I mean, we know that there's so many SI joint fusion companies out there. Will that be your last step, or will that be, where do you go as far as conservative therapy and so forth? And what works for you, I guess?
I do believe that sacroiliac joint is a problem in many patients. And actually, I think the sacroiliac pathology probably explains all what we've seen over the years since I started my training, all this beautiful fusion. The surgeon was so happy, so beautiful. And the patient said, it's beautiful, but my pain is the same as before, sometimes worse. I think this was a misdiagnosis. Patient, and I see a lot of patients now, for example, I see a patient with severe, I saw one yesterday, a patient with severe spinal stenosis and spondylolisthesis on the MRI, and the pain is clearly sacroiliac. I did one injection yesterday. The patient called me at the end of the day, said, my pain is gone. So it would be easy to misdiagnose and operate on the spine on this patient. And I think that all the sacroiliac problems that has been mentioned after artificial disc fusion are mostly a diagnosis issue. I mean, what I do now for my back pain patient, the first thing I do when I examine them, I start with the sacroiliac, get it out of the way. And if I have any doubt, I inject it and I re-examine the patient and see. And if the sacroiliac is totally normal, then I can peacefully treat the spine, because I don't see why an artificial disc will give you a sacroiliac problem. I don't. It actually makes no sense, because by restoring motion, you should even alleviate the stress on the sacroiliac. Now, for fusion is a different story. With long fusion down to the pelvis, sacroiliac is the next joint down, and we understand that it could be affected. But for an artificial disc, I'd never seen that.
Yeah, and that's mostly been where everybody's kind of directed is misdiagnosis, and I completely agree with you with that. So I think that is spot on. And then where do you want patients to begin? Do you want them to email you first? How would you like to progress to start with that?
I have an email address that I use for all my patients. It's info@mo-spine.com. This email goes directly to my phone. It's a special for patient, and I will answer personally, and I will give the direction, and I call the patient. If the patient is a phone number, I call them. And I have a very boutique type of practice. I have no PAs. I do everything myself. And I had a PA at some point, and I had only complained by the patient, so I decided to stop. And the funny thing is, the PA used to spend like an hour on the phone with the patient, and then at the end of the conversation, say, "Oh, we still want to talk to Dr. Bitan." So it was completely counterproductive. So I do myself. So if a patient email me with a phone number, I call the patient right away and see what the story is, and we have a direct contact directly. Also, I put on my new website, which this was launched like 2 days ago, a link where they can upload their images. So they don't have to send a CD anymore. And I can look at it directly and I call the patient back. And usually it's pretty smooth. And I see a fair number of patients from your group. And so far it's working pretty well.
And, you know, part of the reason why we're having this conversation today is because everybody's been extremely happy with what you've done. And, you know, I just want to congratulate you for doing great work and really want to thank you for your time today. It's been fantastic. And, you know, Margaret will probably share with you, probably within 24 hours, you'll have 50 likes and probably 80 comments from people watching the video. And one thing that we really try to do with the group more than anything is have these patients watch these videos, because they can learn so much. Because when you say, well, I need to check your SI joints. Some people, you know, many patients will be like, well, what? You know, I have no idea what you're talking about. So we really try to have them come in and understand and make that process easier for you. And they can say, okay, it was my SI joint. I don't have to have a fusion or an artificial disc. So you answered a lot of good questions, and I think it was brilliant. And I hope you enjoy your beautiful weekend there in the Catskills.
Yep. Thank you very much. I'm going to go for a motorcycle ride now.
All right. Thanks again.
Okay. Bye-bye. Thank you very much.
Hold on.